Thank you very much for your kind introduction, and it's a privilege to be here. Thank you all for coming today. I look forward to working with you in the months and years to come. So I'm going to talk about multiple sclerosis in general, just give a brief outline about the disease itself, the facilities at the Sturdy Multiple Sclerosis Center, and how to access the Sturdy MS Clinic, also how we are involved in patient education in addition to patient care, and what are our future plans for the facility. So what is multiple sclerosis? Multiple sclerosis essentially is a disease of the brain and the spinal cord. And brain, as you know, is essentially who we are. And spinal cord is the connection between the brain and the rest of the body. So multiple sclerosis is caused by an attack of the immune system on the brain and the spinal cord. The immune system, which is supposed to basically protect us from infections, in multiple sclerosis turns against us and tends to affect particular parts of the brain and spinal cord. It affects the nerve cells, and nerve cells have this structure where they have a cell body, which is the control center of the cell, and this axon, which is like a cable that transmits the information from this control center to the rest of the body, and also does it in the opposite direction depending on the type of the cell. Now this cord or this cable has an insulation around it, which is also known as myelin. It is this insulation or this myelin sheath is what is affected in MS by these immune cells. And what happens is that this myelin sheath, which is normally encircling the cable or the axon, gets damaged and the axon becomes exposed. And this leads to an impairment of nerve conduction. So all the information that needs to be sent either to or from the brain is not conducted in the right way in patients with multiple sclerosis. And if you look at brain sections, it literally creates holes in the portion of the brain which has those cables, which are known as plaques. Brain tries to repair them, and these areas where you see these white lesions, they tend to become more remyelinated or get their insulation back a little bit, but still not like the normal blue staining that you see for a normal white matter or the part where the cables or the axons run. So essentially, multiple sclerosis is a disease that affects the connections between the brain and the rest of the body. So you can imagine how it affects a patient. The brain is responsible for most of the functions that we identify with ourselves, including our vision. So we have the nerve cells conducting the information about our surroundings, the visual information to the brain, and if those nerves are affected, patients present with vision changes. They can have decreased vision, they can have double vision. Patients may have numbness or weakness or imbalance. Again, this is due to impairment of transmission of information either to or from the brain. And that is due to the influence of the disease on the spinal cord or the brain itself. In MS, patients also have cognitive changes because, again, for thinking, the brain cells have to communicate with each other. So MS doesn't just affect your vision, your motor system, your sensory system, but also affects the higher mental functions, and patients have a lot of cognitive changes. A lot of patients have fatigue, which is a very common symptom that patients experience, and that is due to chemical imbalance that is caused by the damage of the disease to these various nerve cells. And patients often have a lot of pain and spasticity, which is again due to impaired control of the central nervous system over the rest of the body. MS is fairly common, especially in this part of the world. As you go further from the equator in both directions, north and south, it tends to become more common. The risk of developing MS in our community here is 1 in 750. A rough number could be 1 in 1,000, and it's 3 times more common in women than in men. And the reason for that is not completely clear, but it has definitely a lot to do with the hormonal influences of progesterone and estrogen on the immune system and the nerve cells. The typical age of onset of multiple sclerosis is between 20 and 40 years, so it affects the young adult population during their most productive years. But it can present across the lifespan. In the United States alone, it affects 350 to 400,000 individuals. So if we say that the population is 300 million and 1 in 1,000, so that comes about to this number, which is also empirically derived. And worldwide, you see that about 2.5 million individuals are affected. So it's a fairly common problem, and the fact that it affects people in their young adulthood makes it even worse. So how do we make a diagnosis of MS? It's based on a combination of clinical features and imaging findings, basically MRI findings, magnetic resonance imaging. So I just mentioned to you that MS is basically an interaction between the nervous system and the immune system. And this interaction that leads to the various changes that I just showed you leads to certain shadows on the MRI in a certain pattern, which, when recognized, help us make the diagnosis of MS. The only problem with this is that some of these findings are not specific, and they can occur in other conditions as well. And that leads to a lot of confusion about whether a patient has MS or not. Because if you look at these so-called white spots, in this particular case, they are in a particular distribution that suggests that this is MS. But if they are in another distribution, let's say they are more in the central part here, then they may be due to other reasons as well. And when patients get their MRI scans read or looked at by a number of providers, there can be some confusion about whether this is due to MS or due to another cause. For example, chronic ischemia in a patient with, let's say, chronic diabetes can lead to white spots in the brain, but that is not MS. And that leads to a lot of confusion and anxiety among patients, but that is what our job is, to help make the correct diagnosis based on the MRI findings and patient symptoms. If left untreated, MS tends to progress over the years. There is an increased burden of disability as time progresses. There are increased changes on MRI, both chronic as well as acute changes. Over time, there may even be shrinkage of the brain itself, and there is a loss of cognitive function. In physical terms, while initially a patient may have normal neurological examination, but over a period of time, especially if left untreated, can lead to significant disability and lead to requirement of a cane for ambulation or wheelchair or being bed-bound in advanced cases if left untreated. So the Multiple Sclerosis Center at Sturdy Memorial Hospital, our aim is to provide specialized and coordinated care to patients with multiple sclerosis. And the goal is to minimize the impact of the disease and to maximize each individual's physical and emotional well-being. And for that, the center has adopted a multidisciplinary approach, which I think is a very comprehensive approach. This is a center where there is a team of neurologists, nurses, physical, occupational, and speech therapists, and social workers, all under the same roof and available to the patient at the same time for a comprehensive care of their problems associated with multiple sclerosis. As you can imagine, management of multiple sclerosis is complex. This includes treatment of acute exacerbations of the symptoms, management of symptoms in general chronically. Disease modification is key and central to management of multiple sclerosis, where we want to prevent the occurrence of these exacerbations or these relapses, and also want to prevent a disability progression. And also, we want to provide support to family and the patient. There are actually now 10 drugs available to help with MS disease modification that tend to prevent relapses and also prevent disease progression. And they may include, they may include injectables, pills, or infusions. And the territory is very complex for a patient to navigate. And our goal here is to help them identify the best medicine for their particular disease and use it effectively and safely. Various drugs have different efficacies, different side effect profiles, and that's what makes it even more complex. In addition to managing the core disease itself, the immunology of the disease itself, the management of symptoms associated with multiple sclerosis is equally or even more complex. And these various symptoms include, as I mentioned earlier, spasticity, pain, fatigue, depression, cognitive dysfunction, etc. And all of them require, again, a complex team-based approach for their management. So in terms of the services offered at the Sturdy Multiple Sclerosis Clinic, we offer this entire range of medical management of multiple sclerosis and related symptoms. We have facility to manage the medication pumps for pain and spasticity. Also provide botulinum injections for advanced cases of headaches and spasticity. Infusion therapies, including steroids and biologicals for the wide range of pharmacological options that are available for these patients. Nursing services, physical therapy, occupational therapy, social services, and speech and language evaluations. I have worked at a few hospitals now, and I am really quite impressed by the range of facilities that are available for patients here under one roof. And patients do not have to make multiple visits to different providers for these things. So it is really very impressive. And I feel I'm very privileged to be working here with the rest of the team. So, and we also offer individual physical therapy, exercise programs, and referrals for outpatient physical therapy. In terms of future plans, we obviously want to expand and consolidate the existing services, but we also want to get involved in advanced cutting-edge research. With this association with Brigham and Women's Hospital, we will have access for our patients here at Sturdy to various clinical trials, biomarker studies, imaging studies, which are being run at that institution and its other associates. For example, one of the forms of multiple sclerosis is progressive multiple sclerosis, for which there is no very well-defined treatment. But there are several good clinical trials that are being run right now at Brigham and Women's, for example, which they are very excited to associate with Sturdy Memorial Hospital and have patients the access to that option. So this is a very exciting part of what we will be trying to do in the next, in the coming time. In the middle of all this complex patient management, we haven't forgotten that given the complexity of disease, our patients need to be educated more and more about the disease. So we have an MS Center open house coming up in November, on November 13 at 5:30 to 6:30 p.m. And anybody who is interested is most welcome to attend this open house. To refer a patient or to find out more about the Sturdy MS Center, you can call this number at 7170 from within the hospital, or simply call the hospital operator and ask for the MS Center. So just want to make another pitch for the MS Center open house on November 13th at 5:30. So it'll be great to see you there if you're interested. So thank you for your time. I'll be happy to take any questions. So gamma globulin is a therapy that basically provides a patient large doses of a substance called antibodies. These are usually responsible for fighting infections. And what this medicine is that they pool the plasma from several donors, like from the blood. They separate the cells, they take the plasma, and that has a pool of wide range of antibodies, which then they collect together to produce this high dose IVIG or intravenous immunoglobulin. The mechanism by which this intravenous immunoglobulin works in MS is that it tends to modulate the immune system. You would think that it would have pro-immune effects because it is actually an antibody. So you're giving an immune substance, an immunological substance to a patient. But when it is given in those high doses, it modulates the immune system in a way that it becomes less active and tends to cause less damage over a period of time. Yes.
Can you identify what laboratory tests you find are very useful in helping you to diagnose MS?
Yes. So just a few weeks ago, I had the opportunity to diagnose a patient with Huntington's disease. Huntington's disease, there is a well-defined blood test. You order that test, there is a genetic mutation, you identify it, answer is yes or no, sometimes gray, but usually yes or no. And you say a patient has Huntington's disease or a patient doesn't have Huntington's disease. For MS, there is no such blood test, unfortunately. Therefore, the process of diagnosis becomes complex. And that's why I said the diagnosis is based on a combination of clinical features as well as now, over the last 15 years, and it is evolving, MRI. In terms of blood tests, we do get some blood tests, and that they are mainly done to rule out other causes of these presentations. So we want to rule out things like immune diseases, other autoimmune diseases, or rheumatological diseases like SLE, for example. So we want to check for ANA or anti-nuclear antibody levels. We also check for Sjogren's antibodies to make sure we are not dealing with something in that rheumatological spectrum. Antiphospholipid syndrome can also cause manifestations like that on MRI, sometimes clinical features also. We also want to do some basic labs to make sure we are not dealing with a B12 deficiency, or we are not dealing with a patient with Lyme disease. Lyme disease is another possible mimic, which again causes a lot of confusion because a lot of white matter changes in the MRI have been attributed to Lyme disease in the literature, which may or may not be related, but we just want to get it out of our way.
Thank you.
You had a slide showing the progression of the disease without treatment. Is there a slide showing the progression of the disease with the treatment?
Yeah, so no, I don't have a slide right now with me, but the thing is that with all the available treatments, we are able to slow down the progression. And that the various treatments, they serve to decrease the relapse rate. So if a patient is having 2 or 3 relapses a year, may, depending on the response, may not have a relapse for years, or may have a significant decrease in the relapse rate. And when the relapse rate decreases, the time to progression to a certain level of disability also increases. The problem starts when patients enter the secondary progressive phase, where the relapses are not the problem, but somehow the neurological function is itself deteriorating. And that is a problem that has not been solved. So there are patients who have been on treatment for 15 to 20 years. They have done relatively well. They would have done worse if they had not been on treatment. But now they have entered this so-called secondary progressive phase, where they're having a gradual decline over months to years, on which the current therapies are not working that much. So that is the problematic phase. And that is thought to be due to the immune system that is resident within the brain itself, rather than immune cells coming from outside and attacking the brain or the spinal cord. This progressive phase is thought to be due to immune cells that are there within the brain itself. And there are no good medications, or at least proven or approved medications, to attack those resident immune cells.
Is there genetic research being done to see what triggers this autoimmune response?
Yes, a lot of research is being done in genetics. So there have been certain so-called HLA types that have been identified that lead to increased predisposition. And now, actually at Brigham, they're doing a very sort of comprehensive genome-wide analysis for patients with multiple sclerosis. Some of the genes that have been identified are related to vitamin D metabolism and its effects on the immune system. So for all our patients, we recommend that they take a good amount of vitamin D and at least have normal levels of vitamin D, because vitamin D tends to modulate the immune system and has been shown not in well-defined randomized trials, but in several retrospective studies to have a favorable effect on the course of multiple sclerosis. So another thing that has recently come up is salt intake, and increased salt intake has been found to be associated with again more immune-mediated damage. So low salt is good for so many other conditions, so we can just add MS to that list also. Although again, no prospective large studies have been conducted, but these are some of the insights that have been either identified or supported by the genetic studies, and this is an ongoing work. Patients who have family members or twins, for example, with MS, they are at increased risk. But even with that, the risk is not 100%. So with, like, for example, for twins, the risk is only 30%. If one twin has MS, the other twin the risk of having MS is 30%, as opposed to 1 in 1,000 in the population. But still, it's not 100%, so it's not completely genetic. So it's a combination of genetic and environmental factors.
You showed a slide that had the white spot turning a little blue, and you said something about the body healing or it beginning to heal on its own. Is that done by medication that's advancing that healing, or is that the body doing it on its own? And are there drugs that are being developed that will help cure the problem?
Yeah, so that's an excellent question. And right now, I think this is the body doing its job. There are no proven medicines that help the body do that particularly. Obviously, when you are you're preventing relapses or you're suppressing the immune system, then body gets time to do that, and that helps it, recover itself. But there is no proved treatment right now that helps the body do that. However, this is a very active area of research for promoting remyelination. This myelin sheath is the one that is affected, so you want to promote remyelination. And several drug companies are actually working actively on several molecules. So this myelin is produced by another type of cell that's there other than the neuron cells. It's called oligodendrocyte. It's a cell that sends its projections and then myelinates the neurons. And there are certain molecules that you can target towards those cells and promote their process of remyelination. There is one antibody that is being worked on, is anti-LINGO-1, LINGO, L-I-N-G-O-1 antibody that people are working on. If that happens, that will be actually huge in management of MS. And in terms of cure, well, no, we don't have a cure right now, but we can manage it. But Dr. Howard Weiner, who is a pioneer in MS and is in Boston, he thinks that we will be able to cure it someday, soon, hopefully. Yes.
Are these patients at risk for infection?
With some of the therapies, yes. There are some of the therapies are very powerful immune suppressants, so they do put patients at increased risk. But again, that's a risk-benefit ratio that one has to consider. And most of the approved therapies are reasonably safe. One of the therapies is an infusion therapy. It's called natalizumab. It's an antibody that prevents the migration of immune cells from the blood to the brain. That helps decrease MS relapses significantly, but it also puts the brain at risk for increased infection. And there is a virus that lives, again, in those oligodendrocytes that I mentioned, that may get activated in patients who do not have these external cells coming in their brain for surveillance of any infection. So there are now comprehensive programs to screen which patients are at increased risk for that type of infection. So we try to avoid offering that particular medication to that group of patients. So with a blood test, you can identify if they have been exposed to that particular virus in the past. And if that's the case, we want to go to other options. In some cases, we may still decide to do that particular antibody, but then that requires very close monitoring and surveillance for development of anything like that. And then there's another antibody called rituximab that's used for off-label use in MS, and that also puts patients at increased risk of infections like sinusitis, pneumonia, etc. And not so much with that virus infection that I said in the brain. But that again, you have to see what are the patient's expectations and what are the how severe the disease is, and so it's not like a life-threatening infection with the rituximab usually, if the patient's immune system is otherwise intact.
Is plasmapheresis a treatment for IMS?
Yes, it can be in particular situations. So if a patient does not respond to high doses of intravenous steroids during an acute relapse, and you have given enough steroids but the response is not forthcoming, then one can go to plasmapheresis to exchange the bad humors that are causing the exacerbation. So in the acute relapse management, it has a role for patients who do not respond to steroids. I don't think so. Yeah. I haven't done it yet. So.
Give us an example of the most striking results or from one of your therapies. Talk about a patient or maybe give an insight to how effective these therapies are.
Yeah, so let's see. Okay. Better way to do is this. So the therapy landscape started in 1992 with interferons, particularly this beta-seron, Rebif, Avonex. These are all belong to this category of interferons. They have been successful in decreasing the relapse rate over years. Over the years, the development of monoclonal antibodies has been the most striking development in the management of MS. So I have had patients who have taken these monoclonal antibodies and their brain MRIs were full of contrast-enhancing lesions representing leakage of contrast material. But after they have been on those infusions for a couple of months, their brains look absolutely very close to normal. It's hard to find, identify where the earlier lesions were. And I mean, obviously, as I said, the stronger the therapy, the higher the risk of side effects. So we keep that in mind. But there are patients who have been on these infusions for years, and when you look at their MRI, you say, did they really have MS at that point, at some point? So, but yes, again, that's not a cure because they still have to have the infusions at regular intervals. So I am, very sort of my go-to treatment for patients who do not respond to other treatments or who have advanced disease are these infusions with the monoclonal antibodies. But yes, we have to be careful. They all have their side effects and potential risks.
I noticed that you use, from your graph, that you use more often Campicap and the Tysabri. And
no, it's not my use. It's basically the literature values for the relapse rate reduction. No. Yeah.
We send out a lot of tests for Stratify for patients that are on Tysabri.
Right.
What percentage of patients would you say are on Tysabri?
So, well, depends. In our practice so far, I would say fewer than 10%.
Okay.
Yeah. We try to avoid using a very powerful drug if we can manage with other medications because we don't want to expose our patients to unnecessary risk if we can avoid that.
Hi, you mentioned that SLP is involved in the MS center.
Oh, yeah.
For speech language, how often is dysphagia achieved for patients?
About a third of cases. Third to one half.
Like to solve
So it's a common problem.
patients going to see for that? Or
No, we can usually manage them with maneuvers, chin tuck, and stuff like that. Yeah.
So that the onset is between 20 and 40, is there any way to screen for it so you can get it before you have symptoms?
Yeah, I mean, that's hard always with these diseases because then you have to subject a large, large population to certain tests that are either expensive, invasive, or inconvenient. There is no right now, a blood screen that you can just do it at birth, and say, oh, you're, and maybe we don't want to do that because we don't want to create that anxiety and, all those issues related to that. So no, right now screening is not an issue. But yes, if somebody has increased risk factors, like for example, family history, then yes, you want to just.
The only reason I ask is someone in my family displays symptoms till in their 50s. By that time, a lot of things are already progressed, so that it's really detected.
Yeah, that's true, and that happens. Patients who especially have a good lifestyle, I think they are able to avert expression of symptoms until late. Not that that's a foolproof way of averting symptoms, but I have seen patients who present in their 50s, 60s, and their brains look really bad on the MRI, but their symptoms are really not that severe. So in MS, this is a known phenomena, a clinical radiological mismatch. That's why I said the diagnosis and the management is basically a combination of clinical and imaging findings. Thank you. Thank you very much.